Thank you very much to Thanwi and to the organisers for inviting me to give this talk. I'm a consultant in adolescent infectious diseases in London, and I'm going to describe the youth-centred services that we provide and aspects of the long-term outcomes for young adults who have been born with HIV, looking particularly at service models of care and how these have adapted during the pandemic. This is an incredibly important topic because we know that 15 to 19-year-olds are the only age group where HIV mortality continues to rise, and that for adolescents and young adults, outcomes are poorer at all stages of the care cascade, and that's both in diagnosis, in retention in care, access to treatment, and in viral suppression. And although over the last decade we have seen considerable improvements, there is still quite a way to go until we reach equity with adults living with HIV in terms of the care cascade outcomes. So if we look in the UK, you can see that we have very, very few, so that's the green, yellow and orange bars, of children under 10 living with HIV. And that's in part really a wonderful reflection of the uptake and the efficacy of PMTCT measures. More than 98% of women giving birth in the UK are tested for HIV with very high rates of viral suppression. So most young people are actually moving or have already moved into adult care. The average age moving from transition from youth services into adult care is around about 18. And if we look at that outcome at aged 18, what was the CD4 count when young people left paediatric care? And we'll see as we go on that actually your CD4 count, your viral load when you leave paediatric care is the real determinator of what happens to you as a young adult. So we can see that over time, there have been real improvements in terms of CD4 count, and that's in part starting treatment earlier, but also in viral suppression, that the regimens have improved both in terms of pill burden, tolerability, and efficacy, but still 73% of young people leaving pediatrics have a suppressed viral load, and that really compares to 90% that we see in adults. So that's the gap between viral suppression rates in children and in young adults that we really need to close. And when we're looking at the clinical outcomes for young people living with HIV, this was the ALFI cohort, which was a 5-year prospective study in the UK, where 300 young people born with HIV were matched with 100 either siblings or teenagers born to mothers living with HIV. And the median age of the cohort in both arms was 16 years. And actually, really reassuringly, what we saw was that there was no difference in the rates of depression and anxiety, in the rates of self-harm compared to their HIV-exposed and uninfected peers. However, rates were significantly higher for both groups than in the general population. And I think that in some ways highlights the very complex psychosocial environment that these young people live in rather than the direct effect of HIV itself. In terms of neurocognitive functioning, the two groups had equal outcomes, except the teenagers who had had a prior CDC diagnosis, and often that was their presenting diagnosis and may have occurred 15 years before, when they presented in infancy with PCP pneumonia, CMV, HIV encephalopathy. And there was no difference also in sexual health in terms of age of sexual debut, a number of partners, etc., between the two groups, which is very reassuring for the young people living with HIV who took part in this cohort. However, at some stage, you do have to move from a family-based care. We run a service where we see children in a paediatric outpatient setting, and their parents are also seen by our adult colleagues. And at around about 17 to 18 years, at the time you finish education. Unfortunately, our setup is that you then need to move into adult care. And the first 4 or 5 young people who moved in the early 2000s over to adult care. Now, adult care is in a sexual health setting. Only one engaged in care. And so we realized we needed to set up a service that engaged young people and kept them engaged in care. And when we discussed with the first few who went over, I think what they found is that as a 17, 18-year-old sitting in an adult sexual health waiting room, where the average age of other attendees was often in the 40s and 50s, they felt judged by the patient group. They also, if you had never been sexually active, to access a local sexual health setting, they felt really quite uncomfortable. So we set up a youth service, which is combined with adolescent doctor and nurse who also work in the pediatric department, so are very familiar with the young people. They may have looked after them for 16 years by the time they moved to the adult care, which was termed the 900 clinic, for no other reason that was the secretarial code it was given. And when we asked young people what they wanted the service to be called, they didn't want anything that was HIV identifiable or that talked particularly about youth services, which is quite good because we have kept the clinic going. Initially, when we set up, we said at 25, you have to move into the main adult service. But actually, the first few young people at that stage were beginning to get pregnant. And it just made sense for them to stay in the 900 clinic, where we could provide, with the adolescent doctor and nurse who work in pediatrics, we can provide the pediatric care for the infants born to these young people. And so they've continued as a lifelong cohort. The oldest young person born with HIV in that service now is 37 years. Over time, we've managed to get peer support funded and integrated within the service. So that's a young person in their 20s, themselves living with HIV, who provide, have their own clinic room and provide support. And it's run as a multidisciplinary one-stop shop model of service, where you can also access psychology, dietitian, pharmacist advice. I think it's extremely interesting that our medical services are really set up to make life hard for adolescents during the transition, that our breakpoint is 16 to 18, you move to adult services. And we can see this is from looking at diabetic control. And what you can see is that adherence goes off in your early teens, remains poor through into your early 20s, but actually then adherence in your mid-20s really improves. And we see this in many, many chronic diseases of childhood. And I think what's really important to understand is it's not transition itself, that actually adherence and attendance becomes more difficult for young people in the later teenage years before they move care. And obviously moving your care can be sort of the final straw, but actually we need to pay attention to younger adolescents while still in pediatrics. And poor adherence is part of other risk-taking behaviours that we see. This is not in children and young adults living with HIV, but in many chronic diseases of childhood, we see that young people take more risks, cumulative risks, and take them earlier. And to me, that really makes sense. If you have a life-limiting condition, you assess risk differently. You live with a heightened risk throughout your teenage years, and therefore taking additional risks and experiencing life. And, young people make bad decisions, but older people make really bad decisions too, and don't really get vilified as much as young people, particularly in the press. And we've seen this particularly during COVID. Yet young people have a real reason to take risks, to make bad decisions and to learn from those decisions. And that's because our brain development is incredibly active during our teenage years. And what you see is that thalamic drive develops first, which is what evolutionary wise has allowed us to take risks. It allows us to get out of the hut, to leave our mother's home. Otherwise, we never would. We'd never leave that safe environment. We need to be able to take risks during our adolescent years. Yet our prefrontal cortex, which is involved in impulse control, in emotional regulation, in planning, in looking at consequence. Actually, those synaptic prunings that's incredibly active during the later adolescent years continue into the mid-20s. And actually, we really see this in clinic, that young people, if you can hold them between those crucial years of 14 and 24 and get them through that period, you really see that in their mid-20s, providing they haven't got very significant mental health or drug or alcohol problems, things really do get better. And this is a young woman who I have known for many years, who you can see really struggled, had a CD4 count below 200, throughout that period of 15 to 24. She managed to suppress for a very short time during 2 pregnancies, has 2 lovely HIV negative children. But at the age of 25, and she can't pinpoint it, she just said, it suddenly wasn't so much of a problem for me and I could take my pills. And you can see that despite having prolonged immunosuppression with a CD4 count below 200, actually, when she gets onto suppressive therapy, her CD4 count is now above 900. And we see this very frequently, but it's about holding young people through that crucial period of adolescence, which is so exciting. There are so many firsts, but it's also so complicated because there are so many new experiences that you have to negotiate. You have to finish your education. You probably move out of school. You have your first relationships. You have more freedom. The importance of your peers and those relationships become stronger. That of your family quite less so. And to negotiate all of that for any young person, but any young person living a chronic disease, and particularly HIV, can be really complicated. And, when we look at, parental loss, so 50% of the young people I live with have lost one or both parents. There's the complexities of living in families affected by HIV. Being a young carer, there aren't many childhood illnesses where our parents have exactly the same illness as we do. And I remember, one young person I look after, she can't remember when she started cooking for her mum, who had the long-term impact of HIV dementia prior to her diagnosis. But she knows she needed 2 steps. So that's probably, cooking for your mum from the age of 5. There's the stigma, the self-stigma, the stigma in families. There's negotiating the whole of your sexuality and every sexual encounter with a potentially sexually transmissible disease, although U equals U has really changed that. And there's the issue that half of the young people I look after have actually been born abroad. So there's the issue of migration, of poverty, and being an ethnic minority. So almost 80% of the young people I look after originate from sub-Saharan Africa. And on top of all of that, we think it's a great time to transition just as you finish school and move out of home. And I think the other thing, when we're talking about the perinatal cohort, as opposed to young people who've acquired HIV from other routes, it is that time of when you choose to disclose your status to somebody, that may be a friend, it may be a sexual partner, you potentially not only disclose your status, but the status of your mother, potentially of your siblings and your father. And, I have a young person who, very much lives quite openly about her status and is a real wonderful peer advocate, but her mother doesn't. And she says, I'd rather people thought I slept around than disclose the status of my mother. So it adds a layer of complexity for these young people. And all of those complicated factors, that parental loss, about 1/3 of the young people I look after have had some form of extra help in school. They may be able to live independently and work, but often have some form of learning difficulty. And the stigma that we see both in healthcare, within families, in that most of the young people I look after, even in their 20s, even if they share a room with a sibling, that sibling will supposedly not be aware of the status of HIV within their families. So how do we help young people negotiate this fragile and wonderful period of life between 14 and 24? So the 900 clinic is afternoons only. You have booked appointments, you'll be seen 2 or 3 times a year, but I think the most important message I have got is that young people want walk-in appointments. So every Wednesday afternoon when the clinic's on, young people can walk in without an appointment and access, whether that be sexual health, whether that be psychology, to see the doctor. And they want the services in a one-stop shop so that they can access all different parts of care. And this has been incredibly important during the pandemic, when to access their GP care, to access A&E has been really complicated. And when we look at this, we looked at our rates of viral suppression in the year prior to our first lockdown, which was March 2020, and that ran at just over 83%. And we looked at the year of the pandemic, which ran very similar, 88%. And although we had less appointments, we also did a combination of remote appointments as well. But I think remote appointments are really difficult for young people. They require you to have access to data and to devices, but also if you live in a shared university house, or if you live in a shared bedroom with a sibling who doesn't know about your HIV status, how do you have an open appointment with a healthcare professional? And, you know, many of the young people I've talked to just said, I'd just say fine to every question you ask me, because what else could I say? How do you then administer long-acting contraception and vaccination? So we managed to stay open during the pandemic on that Wednesday afternoon. We provide a service to support adherence. It's antiretroviral therapy isn't the most important bit of clinic. Staying engaged, keeping that conversation going. We always say to young people, even if you're not on your medicines, we want to see you, to provide sexual health, contraception, vaccination, but also to keep that conversation going so that we can move towards adherence to antiretroviral therapy. You know, having said that, as you can see, nearly 90% are on suppressive antiretroviral therapy, but it's that fragile 10% who really need help and support. And this is Maria, who had struggled with antiretroviral therapy for a very long time, despite peer support, despite psychology, despite video observed therapy, despite financial incentives and rewards. And actually, she had very minimal resistance. And in the end, with discussions, we got to the point where we talked about obtaining compassionate use, injectable rilpivirine and cabotegravir. And for her, you can see that going on to injectables, she's managed to keep her viral load suppressed, and her CD4 count has risen from 30 to now over 400. And for some young people who are engaged in care, the newer formulations, long-acting injectables, hopefully the depot preparations of the future really offer hope. And looking at adherence, you know, there have been many studies in adults to look at adherence to antiretroviral therapy, but actually you can see from that table much less in adolescents, although there are some wonderful studies ongoing at the moment, but have been impacted on the pandemic. But this is where we really need to advocate for young people that they should be involved in research just as much as the adults. They are a minority group, and people don't like doing studies in adolescents because of, you know, the difficult conversations, the difficult ethical issues, the difficult engagement issues. They fear high dropout rates for studies, but it's incredibly important that we advocate for young people. So let's look at the outcomes in adult care, and this is looking at the whole UK cohort. This is looking at some lovely work that Hibbo Assad did, published in HIV Medicine. But what you can see is that around about 10% within 5 years have either died or had a new AIDS diagnosis. But the predicting factors are how young people exit paediatric care. And that's why it is so important in pediatrics, particularly in those adolescent years, those early adolescent years between, you know, 14 and 18, that your the CD4 count as you exit pediatrics is what predicts how you will do as an adult. When we look at our own cohort, we are really proud that in 12 years that our combined loss to follow-up and mortality rate over a 12-year period in our cohort is less than 5%. But despite having high levels of engagement in care and now nearly 90% with an undetectable viral load, we still see that the mortality compared to their HIV uninfected UK peers is 10 times. They're driven really often by the rate of malignancy, which is 10 times the normal general population. And now increasingly we're seeing the rates of psychosis. And actually the long-term impact of HIV, we see it in their 20s. It's not in 10 to 19-year-olds, and that's reflected in hospital admissions, where hospital admissions in the 20 to 35-year-old age group are, 3 or 4 times that of 10 to 19-year-olds. And that doesn't include any maternity admissions. And really surprisingly, what we see is that rates of admission to hospital in young adults, those between the ages of 20 and 35, are 4 times what we see in adults living with HIV. And the median age of our adult population is, well into their 50s and 60s. And the factors associated with admission, again, we see that ever having a prior CDC diagnosis. So that impact of what happened to you as an infant continues to impact in your 20s and 30s. And most of those admissions were infections or AIDS diagnoses associated with immunosuppression and long-term poor adherence to antiretroviral therapy. When we look at malignancies, we've seen quite a wide range of malignancies. They are driven by lymphomas, but we've seen hepatocellular carcinomas. The images below are of a rapidly progressive B-cell lymphoma in a young man in his early 20s who had been off antiretroviral therapy for a very long time and sadly died. I think it's the importance of addressing the traditional risk factors for malignancy, the importance of viral suppression, although a word of warning, half of our young people who've developed a malignancy have been suppressed and often for over a decade, but may have had a decade from birth to early childhood where they didn't have viral suppression. The importance of hepatitis B and HPV vaccination and of screening both cervical and for hepatocellular carcinoma in those who are co-infected. Hopefully, with earlier treatment, starting in earlier childhood and treating from diagnosis, we will see less of these long-term issues. If we move on to mental health diagnoses, and I was talking about seeing high rates of psychosis, but in our setting, if you are a migrant, a first, second generation or even third generation migrant, you have an increased risk of psychosis. If you live in poverty, if you have unemployed parents, if you are a looked after child within social care, but also if you have had any form of neonatal infection, any form of brain injury, if you have an underlying learning disability. And many of these factors we see that are in the general population that are risk factors for ever developing a mental health diagnosis, particularly psychosis, are very prevalent in our perinatal population. And if we look at our cohort, rates of anxiety and depression are higher than the general population. However, they're similar to their HIV-exposed uninfected peers, and that really points to the familial, economic, social, environmental factors. Indira Malik did some lovely work looking at the rates of psychosis within our population, which was 7% had ever had a psychotic episode. The median age was in your early 20s after you transitioned to adult care. And that compares to a UK population rate of about 5% of 16 to 24-year-olds. And the risk factors were, again, not being virally suppressed, although 2/3 were virally suppressed, but also having a past CDC diagnosis, often again in infancy, so looking at the impact of that 20 years later, having had a previous mental health diagnosis and also having an underlying learning disability that might have been quite mild, but the impact of that neuroinflammation, the uncontrolled HIV, and the damage done in your infancy. So I think, what really begins to come home to me as I have the privilege of working with these young people well into their 20s and indeed into their 30s is the impact of infancy, of viral suppression as you move from pediatrics to adult care, and the great importance. And what I hope for the next cohorts of children growing up is that with early diagnosis, which is so incredibly important, and early treatment with more modern antiretrovirals, the impact of what your experiences in infancy will improve as you become an adult. And this is really important because there's so many wonderful things watching young people grow up. I've worked in the clinics for 25 years. It's been an utter privilege, and it's really lovely to see young men and women having children of their own. However, if you compare, and this is global UK data, if you compare the perinatally acquired with young behaviourally acquired women, we still see that they do struggle with adherence, but actually adherence improves throughout pregnancy. But we're still the perinatal cohort 3 times more likely to have a detectable viral load than their behaviourally infected peers. We are really pleased. We've had over 30 children born, all not living with HIV, which is just wonderful. And as one young person, we were talking about future cure for HIV, and she said, I've had my cure. I've got 3 negative children. I have an undetectable viral load. I'm in a relationship with a wonderful man, and my children are my cure, and I'm not searching for anything more. And I think that is, it's a wonderful story to have been part of that journey. So in summary, what works? Open access, the walk-in appointments, that has just proved in terms of retaining young people in care. And indeed, we've had people who've been out of care for 2 years and have just walked in on a Wednesday afternoon, and they're never shouted at. Nobody says, why haven't you been here? It's just a smile. How lovely to see you. Tell me what you're doing. They need to be afternoon appointments. They need modern methods of communication. They don't like letters, it's texts and WhatsApp, a multidisciplinary approach. And what they like is the continuity of care from pediatrics to adults. And they want people to listen and to be compassionate, which is actually what we all want as adults from our healthcare. And they very much want it to be multidisciplinary, and they want to be part of research, but they want that research to fit in with their general care visits. And, I think this poster from the WHO, it says it all. They are a unique population. We have geriatric medicine, we have care for pregnant women. We don't really serve our adolescents very well, both in healthcare, but actually in society. So there is massive to celebrate. It's been a wonderful journey seeing these young people grow up, become independent adults. But there are the long-term consequences of HIV, and they are an unknown, and the emerging population in their 20s, late 20s and 30s, are walking a journey that hasn't been walked before. And I think what everybody needs is hope. And this is the London patient. So this was the second adult cured of HIV. And that hope of knowing there will be alternative forms of antiretroviral therapy, that the cure agenda is still, it may have been slightly curtailed by COVID, is incredibly important for young people. And I think for healthcare providers, what we need to remember is when we're planning services and when we're, working with young people, that actually, their driver, we say young people are the most rebellious section of society. They're not. They're the most conformist, but they're trying to conform to their own peer group and not conform to old people like me or to their parents. And it's really hard to be different. And we need to set up services that minimize the disruption to their lives. They don't want to be telling school that they're missing, that occur in the holidays, and be very empathetic towards that. I'd really just like to thank the children and the young adults, and now the wonderful thing, the not so young adults of the 900 and family clinics, and the wonderful teams of people I work with. Thank you for listening.